Okay, awesome. Okay, so good afternoon, everyone, and thank you for joining today's OCI Downtime Recovery Orientation. Just wanted to introduce myself. I'm Danica. I'm a business analyst with RCQ, and I'm joined by my colleague Quentin as well. In this session, we will be covering the general recovery process that applies to everyone. And then later on in the session, we'll review the ED, inpatient, and newborn specific workflows. I do want to mention that this session focuses specifically on OCI recovery activities, and so we won't be reviewing detailed downtime procedures as we assume everyone is familiar with what happens during downtime itself already. Before we begin, just a few housekeeping items. If you have questions throughout the session, please feel free to type them into the chat as they come up. You don't need to wait until the end. It is best to ask questions in the moment as recovery workflows build on each other. If you'd like to speak, you can raise your hand. We'll also be pausing at a few points during the session to check for questions before moving on. Please keep your microphones muted unless you're speaking, especially if you're joining from a work area where there's background noise. I know everyone here is familiar with Teams already, so I won't be going over the symbols on the Teams toolbar today. And also, we will be recording the session for those who cannot attend today. And I think we are recording already, so if there's no objections, I will move along. Just a little bit of background. What is OCI downtime? OCI stands for Oracle Cloud Infrastructure. And as a part of this initiative, the CST Cerner database is being migrated to Oracle's cloud platform. What makes OCI different? So unlike a typical planned downtime, which may only last 1 or 2 hours, OCI downtime is approximately 10 hours long. Because of the length of downtime, recovery activities need to happen differently than they do during a normal downtime. Therefore, there are stricter recovery timelines. So registration staff will receive early access to the system beginning at 3 a.m. At 5 a.m., clinical recovery begins. So this creates a very important dependency. Registration recovery must be completed before clinical teams start the recovery activities because nurses and physicians, they'll need encounters available in Cerner before they can complete their own recovery work and other downstream impacts. And that's why today's session is focused almost entirely on recovery. So this slide shows the overall recovery timeline for ED. Recovery staff will begin preparing at 2 a.m. Between 2 and 3 a.m., staff will be reviewing the recovery SOP. They'll be collecting required paperwork like downtime forms, and they will also test their logins. So registration will be given early access, and so you will need to access the system in a different way, which we will show later. At 3 a.m., it will be hands-on keys. A clerical recovery begins and registration back entry activities start. For ED specifically, they will first complete quick registration of all downtime patients. Next, they'll use ED Modify to fully register all in-house patients, including patients who may already have been admitted to a unit. Once those patients are completed, discharged patients are moved to designated downtime locations, and we will show you this later in the session. Clinical recovery activities begin later at 5 a.m. And at this time, the clerks may take their breaks and complete the full registration for the discharged patients afterwards. Are there any questions so far? Hearing none.
Rosalind has a question.
Oh, yes, Rosalind.
I was going to type it in the chat, but I think we may have to tweak the previous slide just for, how the admit orders are going to be done at 5 after 5 now. And like that box will need to be moved. And then I'm thinking that should we list not just ED quick reg, but newborns in the green between 3 to 5, just to account for everything, because it's not going to just be ED patients, right? So just some suggestions.
Yeah, I was making those on the side as well about the same thing. I think there was a lot of focus on ED when we first made this, but because it's meant for all areas, I just do think we need to make it a bit more generic. You probably don't need as much detail in these as well, because I'm going to cover it in later slides. But the blue section at the bottom, admitting orders, bed moves from 4 to 5, that was TBD nurses and clinicians getting early access, and that's no longer going to happen. So that is all going to start at 5.
Okay, sounds good. So do we want like an overall recovery timeline, not just an ED recovery timeline?
Yeah.
Okay, sounds good. Yeah, we can tweak this. Thank you. Okay, so I'll move on to downtime support and resources. So several support resources will be available during downtime and recovery. Your registration captain will be available to assist with organizing recovery activities and escalating issues when needed. For larger sites such as VGH, St. Paul's, Richmond, and Lionsgate, RSDQ will be on site for support. For all sites, support will be available through dedicated Teams channels. Details regarding Teams channels and support contact information will be communicated closer to downtime. We also will have a command center and also the SOP. You'll receive the recovery SOP before downtime begins, and the SOP contains the step-by-step process that support everything covered in today's orientation. Keep moving along. Forms required for recovery. During downtime, registration becomes a paper-based process. So patient arrivals, registrations, transfers, and discharges are all documented on paper. When recovery begins, these forms become our source of truth. So the documents shown on this slide are the primary forms that you'll be working from during recovery. These forms contain the downtime numbers, patient information, and activity details that must be back entered into Cerner. And this is why accurate documentation during downtime is so important. Everything we enter during recovery will come from these forms. Okay, and we have a golden rule in recovery, and it's that all downtime numbers used during downtime must be back entered into Cerner during recovery. This is a key message that will repeat throughout this session. If a downtime number was used, it must be entered into Cerner. Even if a pre-existing MRN exists, a pre-existing encounter exists, or the number later turns out to be a duplicate, the number must still be entered. The reason why is because that number exists on paperworks, labels, face sheets, patient trackers, and other documentation, and paperwork and Cerner must always match. So now we've covered the key concepts behind OCI recovery, support resources, and the forms you'll be using. Before we move into the demos, are there any questions about anything we've covered so far? I'm hearing none. So I'll hand it over to Quentin.
Oh, thank you, Danica. I will start sharing my screen, and please feel free to let me know if you cannot see it. And also, feel free to ask questions or stop me or raise your hands for any questions, or you can just type into the chat. My demo will include 3 parts. So the first part will be how to do the early access. And the second part and the third part will be downtime at person and how to do downtime at encounter. So I will first demo how to do the early access during 3 a.m. So because that's the early access, so we cannot use the normal Citrix server, so that the regular like application icon will not will not work. So we have to use a dedicated, like special Citrix server. There will be two links that you can access this Citrix server, and it's mentioned in the SOP. So today I will use just one of the links as an example. So once we are in that Citrix server, we will go to categories and we will go to support folders. And then under support folders, we will find a folder called P0783 RBS testing-CST. And just like how to open the regular applications, we'll just click that. Maybe I waited too long, so I will do it all again. Support folders, P0783 RBS testing, and I will click it and wait a little bit for the folder to open. So when we are opening that folder, there should be a error message, error windows, like warning windows pops up like this one. So it's just like a warning. So we can just click OK, and the folder will pops up. So in that folder, we will navigate to the center program files. So we'll double click that. And under that, we will find the application you will need. So for ED clerks, most likely they will need FirstNet. So we can use the search function here. So FirstNet, and that application will pops up. If it's PM Office, then we can search PM Office as well. So if you double click the icons here, and the program should be opened. Like here. So that's how we do the early access during 3 to 5. And it's very similar to previously how we do like e-domain. So that's the way how the clerks, they will do the early access. And I will post it here for any questions or unclear items. And I'm happy to redo it. Okay. So there's no questions. I will move to the next demo. That will be a downtime add person. So in most of for ED clerks, they will use FirstNet, but in today's demo, I'm just using PM Office to save some time. But the conversation they will use in FirstNet and the PM Office, they should be same. So FirstNet, they will use the clerks, they will use the conversation launchpad. But in PM Office, it's much quicker. So today's demo, I just use PM Office. And the first two demo, I will just following a happy path. So we will assume that the patient is a new patient. They never been to BC before. So that patient doesn't have a PHN. They doesn't have MRN. So during downtime, they were assigned both a downtime MRN and the downtime encounter number. Here in PM Office, so before we start, a very important note is that for ED clerks and other recovery clerks, they cannot use the regular uptime conversation. For example, add modified person, ED quick reg or ED quick reg. They have to use the downtime specific conversation to add person and add encounter. So here is downtime add person and downtime add encounter. For ED clerks, they will use downtime ED quick reg. And for maternity, they will use downtime newborn quick reg. So in today's demo, to save some time, I will just use the downtime add person and downtime add encounter to save some time. So the first action is to add a person in, and we will double click that conversation, and we'll search for that patient. During recovery, the clerk will have to refer to the list of downtime MRN. I know some of you folks have generated the downtime numbers for the units, so they will refer to that list for the patient first, last name, and date of birth. So last name today, I will just use some simple naming conventions to save some time. And the random date of birth. And there shouldn't be, because that patient is a new patient, there shouldn't be an existing record. So I will click Add Person. And here I will use Richmond as example. And now the Downtime Add Person window will pop up. The first thing we have to do is to enter the medical record number. This is now no longer like auto-generated because the Downtime MRN is manually assigned. So here we are back into that number. And the recovery clerks, they have to enter twice. And during the twice entry, they have to match with each other. And during recovery, we always instruct the recovery clerks that it's always best to manually type in these numbers twice instead of copy and paste the first field to second field, because that's an important safety check that the numbers they enter twice are exactly matched with each other. So here I will use a number here and enter the number, manually enter the number again. So if the number is never being used and the two entries match with each other, there should be no warning messages pops up. But there are two common errors that will happen. The first common error is that this MRN is already used by another patient. So I will change the number to already used number, and we will see what will happen. So if I change to this, and a warning window will pops up, says this alias is assigned to another person or encounter, please enter a different alias. So that basically tells the recovery clerks that this number has already been used by another patient. In this way, they either have to check if they enter the correct MRN or not, or they have to assign new MRN. But if a new MRN was assigned, then the clerk have to let the clinical team knows that the downtime numbers during recovery has been changed. And so they will be notified all the downstream systems, including lab, MI, etc. And the another common errors is the two entries entered here doesn't match with each other. So here I will just change the last two digits on purpose. So then we will see if anything will happen. So if the numbers you entered wrong here, they don't match with each other, there will be no immediate warning window pops up. But when you click open, try to click complete to finish that conversation, then a window will pop up says the MRN numbers entered do not match. Please re-enter. And then if you click OK, it will erase the numbers, and you will have to the clerks have to enter the numbers again. So that's the two common errors when they type into the downtime numbers. So here I will just re-enter it. If the numbers are entered correctly, there shouldn't be any warning windows pop up. Okay, so once the MRN has been entered, then we will following through to enter the demographic information. For all those demographic information, the recovery clerk, they have to refer to the downtime face sheet for the information. So during downtime, they always have a copy on their desk. So they will have this information on hand. And here I will just use some simple values to speed up our demo. Random address, and those are random phone number. And here, unless it's specifically mentioned in the downtime fake sheet, then the endogenous identity is always default to unknown. And for additional contacts, they will refer to the downtime fake sheet as well for the additional contacts. And here to save some time, I will just click complete. So now the downtime add person step has been complete. Remember, if that only this step is only applies when the person was assigned downtime MRN. So if that patient already has existing MRN and a downtime income that only a downtime income number was assigned during downtime, then we don't have to do this step. We can directly jump to the step 2, which is downtime add encounter. And again, for ED clerk, they will use downtime ED quick reg. But for today's demo, I will just use downtime add encounter to save us some time. So double click that conversation and the patient search window will pop up and we will search that patient again. And that patient name will, that person will pops up and we will just click add encounter. And here we'll use Richmond as example 2. So here, because that person was they never been to BC before, so they need a PHN. So we were not gonna select any records from the EMPI window. But during downtime, in some cases, especially for ED area, sometimes they might have to assign a PHN during downtime. Because of sometimes the lab might need the PHN numbers. So if this is the case, then the clerk they will use the HealthNet to request PHN for that patient. So what if the PHN was requested during downtime, then you should notice that there is a match record here. So then in this case, the clerks will have to select that record. But in this case, because that patient doesn't have a PHN, so we will select cancel. Click continue. And then later we will request PHN for that patient. So we'll double check their demographic information, make sure it's correct, compare it with that downtime phase sheet, and then click submit. An important note is that the request PHN window will only show when in the step of downtime add encounter. It will not show in the downtime add person. So that's the difference between the uptime. And the PHN should auto generate it. And the same here, we will have to enter the downtime income number twice, and they have to match with each other. So here I will not demo the error message again because it's already showed from the downtime add person step. Okay, and we will double confirm the demographic, and for indigenous identity, again, if it's not specifically mentioned in the downtime phase sheet, it's always default to unknown. For encounter information, we will select the desired values for arrival by ambulance. So if in the downtime phase sheet it is mentioned, if it's marked as EHS, then we will select the values that match with the value. Otherwise, if there's no EHS mark on the downtime phase sheet, then we always default to known ambulance. And the source of ID, we always default to none. Unique, I will just do a random unit. For provider information, the clerks will refer to the downtime phase sheet. And in today's demo, I will just use test Alex. If the family doctor, the PCP information is recorded in downtime phase sheet, then we will have to, the PCP verified will be default to yes. Otherwise, it will be default to no. The referring provider, I will just do test Alex as well. And for reg date and time, it is important to let the reg clerk know that they have to backdate the reg date and time to the actual actual registration date and time. This is because the length of stay has to be accurate, and because this information is dependent by many other teams, like for example, reporting, the downstream lab and MI. So we have to always remind the clerks that backdate the reg date and time to the actual date and time. So here I will just assume that it was registered at 11 p.m. So here, and then once all the information has been entered, we'll move to insurance. For the insurance status in Canada, it's always unknown, default to unknown. And for accident and injured information, then the clerk will have to refer to the downtime accident information form. It's another form, so it's different from the downtime phase sheet. That form is specifically recorded the accident and work-related information. Again, they should have a copy retained in their desk, so they will have that information on hand. But in today's demo, I will just do no accident work related and no work related. And for primary insurance, there is another important thing is that they always remind the clerk to backdate the effective date. Because if we leave it blank, then it will default to today's value. So because the recovery always happens on Sunday, so but the downtime starts on Saturday evening, 7 p.m. So if that patient was registered during Saturday, then they have to backdate the effective date to that Saturday value. So for example, here it will be August 22nd. So the first day that the downtime will start. If the clerk leave it blank, then it will default to 23rd August 2026. So this will cause significant troubles to finance because on their understanding, if the patient visit is on Saturday, but their insurance effective starts on the next day, that means the cost for that day's visit will be self-pay. So there will be billings generated for that patient. So and we definitely don't want that happen. So that's another important note, that always remind the clerks to backdate the insurance effective date. That only applies if that patient's visits on that Saturday. For Sundays, they can leave it blank. But here I think the system will not allows me to enter future date, so I will just clear it. So then we'll move to additional contacts. So here I will just use a simple values. The first name is test spouse. The address will be same as the patient, and preferred phone will be a random. And once all the information has been entered, we will quickly do a quality check for all the values and to see if it's matched with the downtime phase sheet and downtime accident information. And once it's all accurate, then I will click complete. And then we will click OK. So then that means this person and its associated downtime income number has been entered into the system. So that's the whole workflow for downtime at person and downtime at encounter. And this is the happy path. So we assume that everything goes fine, that there's no errors happens. But the real life is there shouldn't be some complicated cases, and we will cover it in later demo. And I will pause it here because it's a lot of information, and to see if anybody has any questions or unclear steps. Oh, go ahead, Razumi.
Sorry, I always have some things. But the demo was great. Thanks, Quentin. I just had a suggestion, unless you were getting to that, that for the demo, instead of the downtime add encounter, could we actually do the downtime ED quick reg? Just because that would be the more commonly used by the recovery clerks, unless you were getting to that. Because I don't know how much time we have in like how much we can demo, but if we had to pick.
Yeah, we discussed this because yes, we agree like the most of the audience they should be come from ED area. Um, but it's just because like we only have 1 hour and if we do the downtime ED quick reg, that means we have to do the ED modify as well. So we are not sure if the time allows us to do that because we have 1 hour, but we always have to give like 10 to 15 minutes for questions or other things or discussion. So we're not
Yeah,
sure if
for
we
sure.
do ED quick reg, then if the time will allows us to do that. So instead we just demo the downtime adding counter.
Okay.
Yeah.
I think the ED modify they're already familiar with. So I wasn't thinking they would, they would need the ED modify too. But yeah, I mean, if we have to pick one or the other, then like just maybe a thought that because the ED quick reg could also go along with add person, right? Downtime add person, and then ED quick reg, like for a patient who's brand new to Cerner.
Yeah.
Something like that, like making up that story.
I think we have to later on we have to go to ED modify because for example the backdating the insurance and also like the special values for arrival by ambulance, the PCP, etc. things.
Oh,
I think
gotcha. Okay,
we have
yeah, I didn't think
to
of that.
yes, eventually we have to go to ED modify. Otherwise it will not be covered. Yeah.
Right, right. Okay, yeah, the other fields that you were showing. Okay, that makes sense. And then the only other thing I noticed you're using the B domain, and I have no idea how you got the PHN. Maybe it is connected to EMPI right now, but I was gonna suggest maybe using E domain instead for the demo because that's the OCI domain. They're similar, but just like E is more up to date with all of our config.
Oh, okay, yeah. I can switch to E domain. But then for E domain, will the PHN, what is the EMPI connected? Like they have a dummy
It should
domain.
be, yeah, that's what I'm trying to find out. We are connected to EMPI in E domain always, because B has been disconnected. So I was surprised how you got a PHN. Maybe they had to do something. But anyhow, yeah, E domain should be connected to EMPI.
Okay. Yeah, then I will at least E domain for the orientation. Well, thanks for the suggestion. I also get used to the B domain.
And then my only last one was going to be I know we are not talking about downtime, but is it possible to just flash up the activity log or the ED quick reg log, whichever whatever we are using for the demo, so they kind of have a sense of what they're looking at on paper and transcribing it into the system? Like maybe just like flashing up with the test patient filled out that, okay, you have your activity log in one hand, and then you're just putting this into the downtime add person or downtime add encounter.
That's a good point. I was thinking like you mean like during demo we can quickly throw them like a
Yeah, just a
screenshot.
virtual copy. Yeah.
Okay, got it. Yeah, I
Yeah.
can do that too.
Yeah.
Like I can get that ready and when the time is that I can just do like yeah, quickly show them a pre-filled form and see we'll refer to this form for this information.
Yeah, that'll just help them know, like, in reality, like they would be looking at that paper and then putting it in the system.
Okay.
The
That's all.
sample image on the slide deck was really good with the filled out rows. So I think if you do something exactly like that for the other forms that they'll need for the rest of recovery, that'll be perfect.
Okay.
Yeah, totally. Thank you.
Yes, I can do that. Thank you, Roswin. That's all very good suggestions. Eh, If there's no questions, I will hand it back over to Danica.
Thank you, Quentin. Okay, so moving along to error cases. There are two common recovery scenarios that we want everyone to recognize. The first occurs when a downtime encounter was used instead of an existing encounter. In this case, the unused pre-registered encounter must be discharged, but the downtime encounter must still be entered. The second scenario occurs when a downtime MRN was assigned to a patient who already has a Cerner MRN. In this situation, the downtime MRN still needs to be back entered. After recovery is complete, a merge request can be submitted to data quality. Again, the key message here is that if a downtime number was used, it must still be entered. And I think Quentin will also demonstrate each of these scenarios. So I'll hand it over back to you, Quentin.
Thank you, Danica. I will share my screen again, and I will demo how to deal with these two error cases. Always let me know if you cannot see my screen, or if you have any questions. Feel free to stop me, and just don't be shy because we are also a learner always. So the first error case is when the patient has a pre-existing pre-registered encounter. So that will most likely happens when that patient has a pre-book appointment. So that means they will have pre-registered, for example, pre-operation in a bed. In this case, I know most of the first action for most of the people would be I should pick up the pre-registered encounter because they're already there. But we always have to tell the reg clerks that they cannot touch that pre-registered encounter. They have to back enter the downtime encounter number, even though that's a duplicate encounter. The reason behind this is because the downtime encounter number has been spread out for all the related units, clinics, for example, lab, MI, or other units, because they all use that downtime encounter number. If during recovery, if we use that existing pre-registered encounter, that means for all those information flow to downstream to other clinic units, then they will get the wrong encounter number. So it's always the recovery clerks, we always have to tell them if there is a pre-registered encounter, you still have to go ahead and pre-register the encounter. So I will start my demo. So for these first error cases, if we are going to downtime at encounter, and when we try to find that patient, say I internal 2, yes. And we'll find that in the encounter history, they actually have a pre-registered encounter number, and it's easy to differentiate because the regular encounter number starts with number 7, but the downtime number starts with number 8. So in this case, we have to leave that encounter here for now and go ahead and click add encounter. Even though that will create a duplicate encounter, but they have to do so. But in this demo, I will not demo how to add encounter again because it's already demoed. But the key point is that they have to go ahead and add encounter, even though there's a pre-registered encounter for the exactly same visit. And then later on, once that downtime encounter number has been back entered, then they have to go to that discharge encounter conversation to discharge that pre-registered encounter. Turn up 2, and we will discharge it as no service provided, creating an error, and the discharge date is the same date as pre-reg date, and the discharge time is 1 minute plus the pre-reg time. So that marks that this encounter was creating error. So this information can be received by or other downstream systems, for example, billing, the finance team, so they know this encounter was created by mistake. And then we will click complete. So So this is how we deal with the first error case when the patient has a pre-registered encounter, but then they were still assigned a downtime encounter number. And the second case is a little bit more complicated. It's when that patient has a pre-existing MRN. So that means they already have a cyst MRN, but they were still assigned a downtime MRN during downtime. So that means during recovery, we will have to create a duplicate record for that patient. So they still have to go ahead and add the downtime record for that patient, even though that patient already has a cyst record. So here, if we are going to add downtime at person, then we search by the internal to. Yeah. So when we are using downtime at person here, the clerk will realize, oh, there is a exactly same patient with the exactly same date of birth, same first name, same last name, same demographic information, the same PHN. So in this way, again the first action for most of people is I should use this existing record, but here we always have to tell the clerks that they have to go ahead and add person, even though that will create a duplicate record. This is because the downtime MRN has to be back entered. And the reason is because the downtime MRN, same as downtime encounter number, it has been used already during downtime to downstream systems and other unit clinics. So on their side, they already associate the downtime MRN with that patient. For now, during recovery, if you are using the existing MRN, then when this information flows to downstream and other clinics and units, then they will all get confused. So here I already do some pre-steps and add that downtime MRN already. So when we are going to downtime add encounter, then we will see what it looks like. Internal to. Internal. Oh. That's strange. Okay, maybe that record has been disappeared for somehow. But normally say if we add that, maybe I will just do over again. Quickly use downtime at person. R. Okay. Mobile phone. Okay, then when we are doing downtime at encounter, then there should be two records. Yeah, so there will be two person with exactly same name and same date of birth, but the MRN is different. So it's easy to differentiate. The regular MRN starts with number 7, and the downtime MRN starts with number 8. So here, the clerk, they have to pick that downtime MRN record, which is blank here. They cannot pick up the pre-existing cyst center record. So here they have to pick that one and continue to add encounter to that downtime MRN record. So here, if we add encounter here, and I will use Richmond as example. If the clerk was by accidentally registered that downtime encounter number to that existing CST center record, then we have to instruct them, we have to tell them to contact DQ to do an encounter move or to do the remediation work. So here, in the EMPI window, they should notify that patient record here. So it's exactly same name and the PHN is there, but the MRN is different from the downtime MRN. It's important to tell the clerks that here is do not select that existing record in this step, because if we select that, the information from EMPI will override to that downtime record, which needs more remediation work. So here they should not select any existing record. They will click cancel and click yes. And the EMPI window will pops up. In here, we are not requesting PHN for that patient because that patient already has a pre-existing MRN, pre-existing CST center record. So they should have a PHN already. So if we request PHN here, then there will be a duplicate PHN. So we'll click cancel here and then click yes to enter into the downtime add encounter conversation. So that will be the same conversation we from the previous demo. So they will just enter information here and click complete. Save us some time. I will not complete the conversation here. It's just to give everybody a point that how to deal with the case if that patient already has a pre-existing CST center record, but they were still assigned the downtime MRN during downtime. How to deal with this case. And once the encounter has been back entered, and then the unit or the clerks have to submit a duplicate merge request to DQ team to merge that two records into one. And then so that's the whole workflow to deal with the second error case. And I know the second case is a little bit more complicated, so I will pause it here again for any questions or unclear steps. Okay, if there's no questions, I will hand it back to Danica, and she will continue with the presentation.
Thanks, Quentin. Okay. So now that we've covered the general recovery process, we're going to look at workflows that are specific to certain departments. We'll start with the emergency recovery and then review inpatient and newborn specific recovery. So the ED recovery follows a very specific sequence. The important times are indicated at the top. There's 2 a.m., 3 a.m., and 5 a.m. Step 1 is recovery preparation. The downtime reg captain will organize the paperwork and distribute work to recovery staff. A best practice before beginning is to sort documentation into 2 groups, patients still in-house and patients already discharged. This is because these 2 set of patients fall under different priorities. At 3 a.m., you will perform a quick reg for all encounters registered during downtime. Then step 3 is full registration of all in-house patients. This includes both patients physically in the ED and patients who may already have been admitted to inpatient units. Step 4 is to move discharged patients to the designated downtime locations on the FirstNet tracking shelf. For most sites, they'll use the yellow locations. VGH will use the HWR location instead, and we'll show you this afterwards, and this will also be indicated in the SOP. Step 5 is quality assurance, so they'll need to verify that All MRNs are entered, all encounters are entered, backdating is completed properly, length of stay appears reasonable. So all of these are to be completed before 5 a.m. Once these are done, discharged patients will be fully registered using ED Modify. I do want to note that you can still use the ED Modify conversation for patients discharged within 48 hours. And just to show you quickly how to move the discharged patients to the designated code orange locations. So in your FirstNet view, you will look for your patient and they will likely be in the waiting room. And then you'll double click on the bed. And here you will select the designated code orange location for the patient. And for most sites, it will be the yellow location. And click OK. And it's as simple as that. And moving on to the inpatient process, but before we move along, is there any questions regarding this process? I'm hearing none. So the inpatient recovery process. For inpatient areas, recovery generally follows the standard recovery process. You will gather your downtime forms, then you'll use the downtime forms to first enter the downtime MRNs and then enter downtime encounters. Patients that have expected arrivals should already have pre-registered encounters, and so you should use the appropriate uptime registration workflow to flip these encounters. Lastly, you'll complete any required encounter updates based on the documentation collected during downtime. As with all recovery activities, always remember, use the paperwork as your source of truth, enter all downtime numbers, and backdate the dates and times appropriately. And if you're ever uncertain, refer to the SOP or seek support from your registration captain or recovery support resources. Newborn recovery. Newborn recovery is one of the few areas where the recovery workflow differs from the standard process. The key thing to remember is that the recovery conversation you use depends on whether the mother is registered in the same facility. So first step is the same. You will gather your downtime documentation. If the mother is registered at the same facility, you will complete the recovery for the mother's inpatient encounter first. Then you will use the downtime newborn quick reg conversation, followed by the newborn modify conversation. If the mother is not registered at the same facility, you will use the downtime add person conversation, followed by the downtime add encounter conversation. And that's really the main point of this slide. The recovery process itself doesn't change. What changes is which conversations you're using. So just want to reiterate, mother registered at the same facility, you will use newborn quick reg and then newborn modify. Mother not registered at the same facility, use downtime add person, followed by downtime add encounter. Another important newborn specific topic is the PHN assignment. This only applies when a newborn is discharged during downtime. And why is this important? It's important because parents will need a PHN letter when they leave, and that PHN must exist before discharge can occur. If the newborn was pre-registered before downtime, a PHN would already have been assigned, and you can simply continue to use that PHN. The exception occurs when the newborn was not pre-registered and the newborn is being discharged home or transferred to another facility during downtime. In those situations, a PHN must be assigned manually through HealthNet. So the rule here is very simple. If the newborn already has a PHN, use it. And if there's no PHN and the newborn is leaving during downtime, one must be created manually. Before we end the orientation portion and open for questions, I'd like to review the most important takeaways from today's session. One is that every downtime number that was used during downtime must be entered into Cerner. Two, paper documentation and Cerner must always match. That's why we continue entering the downtime numbers even when their duplicates are identified. Three, always remember to backdate registrations and encounters using the information on the downtime paperwork. And four, registration recovery supports clinical recovery. And the goal is to have the encounters entered before clinical recovery begins at 5 a.m. And so we'll now open the floor for questions. I am hearing none. Is there any in the chat? None in the chat. Yep, so you'll also receive the access to the recovery SOP before go live. If you have any questions, just feel free to reach out to us at any time. And thanks everyone for attending this session. I'll hand it over to Abe to discuss support during downtime recovery.
Okay. Thanks, Zach. Thanks, Quentin. A couple notes about the demo. We'll go over them later. But while we have everyone here, downtime support. So we are sending staff to the 4 busiest sites: St. Paul's, VGH, Lionsgate. And I'm forgetting one. Should know. Richmond. Thank you. Thank you. So all those will just be sending one person. It's a lot of sites to cover for a downtime happening across every single site at the same time. But those are the areas where we've asked to have about 4 to 5 clerks each, because they have the greatest volume of recovery to enter. And many of them are also going to be covering recovery duties for smaller sites. For example, St. Paul's is covering the recovery for MSJ. So MSJ needs to be faxing their downtime forms over to them. Lionsgate is covering for a lot of the smaller North Shore sites. So there are a bunch of exceptions out there. And the more students or the more people you have on site, the more likely are that someone's going to run into an issue or need some support. We'll have a support channel available or on Teams. They just type in with questions. And that's fine for areas where there's only one person, but for areas where there's 4 to 5 clerks, we do need to get issues resolved more quickly. So just by having someone there in person, we can respond to those much faster. Sorry, give me one quick second. I need to deal with. Sorry about that. So when we're there on site, all staff are going to go through the downtime course, so they should have a clear idea of what to do during downtime. We will show them examples of the filled out forms to use. Every site is supposed to have a designated clerical downtime captain who will also be responsible for collecting all of the forms to make sure they get to the right people. In most sites, this is going to be the HIM supervisor. But we are there to ensure that there are no hiccups, because the 3 to 5 a.m. timing is so tight that we do need to make sure that they are ready, hands on keys, right at 3 a.m. So really, we are there more as a support, similar to Go Live. The clerk should know what to do. They've done the course. They have this orientation session. We also have a 17-page SOP. So I'll pop the link in chat as well for those who haven't seen it. And a lot of the rest of us will be printing this out, make sure it's available to staff. We're there in case they have issues, namely in that first 2-hour window from 2 to 3. It's when clerk shifts begin. Making sure that they have all the forms that they need, that they have actually tested their login access. If there is an issue with the login access, that they escalate to us right away so we can reach out to the correct folks in the command center and get their access working. All that to ensure there's no delays. They're actually doing their back entry, hands-on keys right at 3 o'clock. Our estimate for how many clerks we needed was padded very generously. I think we have like an extra. Both sides should be able to really do it comfortably within an hour and a half or less. They have 2 hours just to account for some users that might be run into issues, or someone might be a sick call, an area might be short. But the goal is make sure they are able to get everything into the system 3 to 5, help the supervisor with the QA checks, because the bigger sites also have much larger volume. Just like with cutover, the concern is, have they entered in everything? Nothing's been missed. Have they duplicated something? Even though we have 20 MRNs that were entered. Are those 20 MRNs actually for unique patients? Did they not enter the same person twice or the same encounter twice? Things like that. And then the rest of the day is just answering questions about the downtime process in general. Pausing here. Questions, comments, concerns? Okay. We will have one person on the dedicated team chat for the smaller site. So the idea is that whoever is at in person at one of the larger sites can handle the bulk of the questions coming from the large number of staff members at those sites. And that way we can just have one person sitting on Teams call for anything else for the smaller sites. Otherwise, we need multiple people on the Teams call, and it'd be harder to address the busier sites where there's 4 to 5 clerks. Otherwise, I think that is it. And Rosalind, your team is also going to be available that night as well? Or hours still being worked out? Sorry, shift time still being worked out for your team?
The early hours on 23rd, right? That's what you're asking. Okay, yeah. So we'll have our support is starting midnight. And it would be mostly focused on the validation of the system as soon as we get the system back from Oracle, and so that it can be validated and released to the sites ASAP after that. So like the 3 a.m. is the planned time. Hopefully we'll be finishing our validation by then, and then the system is good to go for registration. And Martina is going to be on shift around that time as well. So we're kind of covering before recovery, so during validation and into recovery and a little bit after that. So after that, my team is going to be 24/7 support, just for any configuration issues as well.
Perfect. Thanks, Rosalind. And for RCQ folks, we are there. We do have some shifts starting at the beginning of recovery. Yelena will be there, I think, from midnight all the way to 7 a.m. But there's also concern from the sites about at the start of downtime, make sure that clerks who have never done downtime before are comfortable with the process. They have access to everything they need. They are filling out the forms properly. My recommendation is always, when you do see, if you are on site and you're supporting and speaking of downtime, what I always do during cutover is watch them do the first couple registrations. I will literally just sit right beside them at their desk and watch them enter in the first 2 to ensure that they're not making an error. So during downtime, I'd recommend doing the same. Make sure they're filling out the full downtime logs correctly. Because if there's an error there that they make in the start of the shift, they're going to keep making an error for the entire downtime period. It's going to cause problems down the road. And again, with recovery and back entry, sit with them as they do the first couple, or at least just one for 4 clerks. I would sit with each of them to do 1 registration each. Again, to make sure there's no issues. They are looking at the right documents. They are entering it incorrectly. They're using the appropriate default values as specified in the SLP. It should all be spelled out. The SLP is written step by step, but a lot of people in the call have taught classes before. You understand that sometimes that's not enough, especially if something that they're new and nervous about. So sometimes just keeping an eye on them and calling out a couple small corrections at the beginning saves us a lot of trouble in the validation step down the road. Yes, Rosamine.
I was thinking for the recovery clerks orientation, are we gonna tell them a little bit about how to reach us if they have questions, like in terms of like the MS Teams channel? And because I feel like by that time, like whenever we are booking that, I think they should have already been added to the channels. If not, then just like kind of letting them know how they can reach us, at least for sites that do not have a person on site for support.
That's a good point. Do we know when they'll be added to the Teams channels?
I think as soon as we give them the list, um, I did see something around that. Where did I see that? Where they were planning on adding people. Maybe the what is August 17th? Is that the Monday? Yeah, I think they were planning on adding or start adding people August 17th.
Because that also overlaps with the first of those sessions, because these sessions will start the same week, the Monday 17th. So
Okay.
they may not all be in
Yeah.
there yet.
Yeah, I think maybe even just putting the name of the channel in the slide or just showing them where they would find the channel, just so they're aware that that's that's how they can reach us for any questions.
Makes sense. I agree. I see RD typing something. Oh, we are losing RD. All right, there's no other questions or comments. I think we're good. Everyone else can log off. Danica and Quentin, I'll ask you to stay back for a couple more minutes. Otherwise, thanks for your time, all.
Thank you so much.
I think I will stop recording then, because
Yeah,
this
we
is
can
more
stop recording
for
at this point.
more for feedback.